Okay. Hello, everybody. We can just wait for more people to join. My name is Camelia. I will be hosting today's webinar for you. I want to thank the Endo-ERN project and the MTG7 chairs and our speaker today. Hedi is MTG7 chair from sex development and maturation department, and Hedi Claahsen is Endo-ERN EPAC member from the Turner Syndrome Support Society. All questions we prefer to be taken at the end of the when the presentation is over, or you can also raise your hand so I can unmute you and you can ask your question in the chat. This webinar is accredited, so if you want to receive your certificate, you can fill in a survey that you will get within 48 hours after the webinar is over. So now I can give the word to our speakers.
Thank you, Kami, and welcome everyone to this webinar, indeed organized by the Endo-ERN, the main thematic group, Sex Development and Maturation. My name is Hedi Claahsen. I'm a pediatric endocrinologist working at the Radboudumc University Nijmegen in the Netherlands. And with me, the co-moderator, that is Arlene Smith. Arlene is a patient representative within the Endo-ERN and board member of the Turner Syndrome Support Society in the UK. And I'm very happy to welcome our speaker today, that is Professor Janielle van der Velden. Professor van der Velden is also a pediatric endocrinology and also my colleague at the Radboud University Nijmegen in the Netherlands. And she's a very well-known specialist in Turner syndrome, and therefore we are very happy that she joins this session. She set up the multidisciplinary Turner outpatient clinic in our center and published many papers, among others the just published clinical practice guideline for the care of girls and women with Turner syndrome. And one of her interests is puberty and fertility in Turner syndrome. She set up the well-recognized Turner fertility trial, and here she's supervised many PhD students on this topic, which is also the topic of today. So Professor van der Velden will give a lecture of about 50 minutes about fertility in Turner syndrome. And then we have a couple of times for questions. So you can use the chat function for your questions, which then we'll discuss after the talk. So Janielle, welcome, and the floor is yours.
Thank you, Hedi, for this nice introduction. And I thank the ERN for the invitation. And I thank the audience for attending this webinar. I would like to introduce you to a couple of girls. This is Elsa. She has Turner syndrome. She's 6 weeks old and has lymphedema, as you can see, and a cardiac malformation. She has a monosomy 45X, and there are no lab results available yet. This is another girl, Romy. She's 6 years old. She has a short stature. She has some neurocognitive problems. She had a horseshoe kidney, and she has a mosaic Turner syndrome. And she has no puberty yet, and her lab results show an AMH of 0.37 micrograms per liter and an FSH of 4.8 units per liter. And this is Christiana. Christiana is 15 years old. She has a mosaic Turner syndrome as well. And she had a short stature, but otherwise no other comorbidities. She had a spontaneous puberty and a recent menarche, and her lab results show an AMH level of 2.1 micrograms per liter and a normal FSH. So my question for today is, how and when do you counsel for fertility options? As we all know, Turner syndrome is one of the most common sex chromosomal disorders in girls, and it occurs in 2,500 female live births. And it's due to a partial or complete absence of one of both sex chromosomes. And almost all girls and women have a short reproductive lifespan in comparison to the general population. And if you look at the natural course of girls and women with Turner syndrome, almost 40% of the girls will have spontaneous breast development. About 1/5 of the girls will have spontaneous menarche, and only 2 to 8% of the women will have a spontaneous pregnancy. And as we all know, there is a correlation with genotype, of course. And there are many studies published who show that there's a correlation with 45X pattern or a mosaic Turner genotype, and that, of course, the odds for having a spontaneous TLRK or a spontaneous menarche are much lower in those patients with a 45X genotype in comparison with the mosaic genotype pattern. And you can also see that in this plot, it's like a kind of a survival plot for the ovaries and for the follicles in the ovaries. And it shows on the y-axis the incidence of premature ovarian insufficiency. And in the orange color, you see the monosomy 45X girls with Turner syndrome, and you can see that the survival rate for the ovarian function is much lower in comparison with the purple line, which shows the mosaic girls with Turner syndrome. But if we think that it's important, the genotype is important in the counseling for fertility in girls with Turner syndrome, it's important to know that there can be a large difference between different cell lines in genotype. This is a very nice study of Graf and her colleagues, and it shows that the genotype in the lymphocytes in the blood can differ a lot from the genotype in other cell lines. For example, here are the buccal cells. So it can happen that there will be 100% of the cells 45X in the blood, while in the buccal cells the genotype differs. And also this can happen also in a lower percentage of 45X in the blood. So I believe that it's important to perform a good counseling for fertility options to have at least 2 cell lines genotyped. How about the hormones? I focus on AMH because I think that's the most important hormone, which is a most important predictor of reproduction in females with Turner syndrome. And I like this picture very much. It's a picture from Caspar Hagen and his colleagues, and it presents with a blue triangle. If you compare the normal ovarian capacity in healthy women, you can see the different stages of the follicle growth, the primordial follicles, primary follicles, the pre-antral follicles, and then the antral follicles, who are mainly responsible for the production of AMH, and then of course the large antral follicles. So if you have Turner syndrome, probably your ovarian capacity decreases, like you can see in the black triangle. And then all layers of follicles are smaller, and also your production of AMH by the antral follicles will be decreased. This is what Caspar Hagen also showed in one of his studies, where he looked at the AMH levels compared to the pubertal function. And this graph shows you that those girls with ongoing ovarian function had higher AMH levels than those with absent spontaneous puberty, and also compared to the patients who had cessation of ovarian function. And also the genotypes are included in this picture. The red patients are those with a mosaic genotype, and the black boxes are those patients with a 45X genotype. And the blue patients are the patients with a different genotype. And also we made a survival plot compared the incidence of premature ovarian insufficiency compared to the AMH levels. And as you can see, there are very low numbers at these ages, so this is not very predictive at the age of 20 or 25, but at the younger age, you can tell that if you have an undetectable AMH level, the ovarian function will decrease very quickly in comparison with patients who had an AMH level above 1. So in conclusion, the genotype and the AMH level are both important predictors for reproductive potential in girls and women with Turner syndrome. But the complicated thing is that there's a very large inter-individual variety, and that complicates counseling. So I think you should always consider, if it's an option in your center, always perform a second cell line for more detailed genotyping, and also repeat AMH measurements, because there's a very high biological variability in patients and also a large inter-test variability. So what are the options for motherhood in Turner syndrome? Of course, you can distinguish a genetic own child from becoming a mother in a non-genetic way, for example, adoption, foster care, or oocyte donation. And each of these options has several pros and cons, which we summarized in this table. And for my talk, for the next 30 minutes, I would like to focus on the fertility preservation techniques. And at this moment, there are two different options for fertility preservation. One of the options on the left side is to retrieve oocytes. And this is only possible after hyperstimulation of the ovaries, and it needs transvaginal ultrasound techniques and also punction, abdominal punction. So it's an invasive procedure that needs still an ovarian function at the time of the procedure. The other option is ovarian tissue cryopreservation, and that's a surgical procedure, and you do not need hyperstimulation on the ovaries, and you can perform this procedure at an early age. So now I would like to focus on both procedures for the next part of my presentation. First of all, oocyte cryopreservation in Turner syndrome. So you do not need a surgical procedure for this procedure. It's not considered as an experimental therapy, but there's still little literature about this procedure and the outcome in Turner syndrome women, which I will present you in the next slides. And you can do it during childhood, but the general consensus and also the recommendations also from our guideline groups is not to perform it at a too early age, because you need a certain degree of psychosexual maturity to undergo this very invasive procedure. And also, most important, you need still ovarian function at the age of 16 or 17 years old. So that makes this option not realistic for many of our patients. So if you look at the literature, there were only 58 cases described in many different retrospective studies, so all small, most of them were small case cohort studies for patients with Turner syndrome. And the median age for this procedure was 21 years old in these studies, and almost all these patients had spontaneous puberty. And a first cycle hyperstimulation resulted in a median of 5 oocytes for each patient. And it will be no surprise that the majority of successful women had a mosaic genotype, a detectable AMH level, and low FSH level. But until now, there's still one case report, as far as I know, of successful pregnancy after this procedure in Turner syndrome so far. So very little evidence for the success of this procedure yet. So recently we published this large case cohort study of, concerning 33 cases. Most of them were mosaic girls with Turner syndrome and also with a spontaneous puberty, including menarche. And our results are more or less comparable with the results of the other case studies in the literature. Like the first cycle, you can see the number of vitrified oocytes, and many of our patients had different hyperstimulations, like cumulative hyperstimulation cyclically, for retrieval of sufficient numbers of vitrified oocytes. And as you can see in this picture, that many of our patients had kind of the same amount of vitrified oocytes in the first cycle. And many of these girls and women decided to go for another hyperstimulation cycle, or even up to 4 cycles. And we also did see a correlation with genotype, with a cumulative number of vitrified oocytes on the y-axis and the percentage of 46XX cells on the x-axis here. And also we found a correlation with AMH levels. And the left graph shows the number of vitrified oocytes in the first cycle, and the right side shows a cumulative number of vitrified oocytes in the cumulative number. And also the different genotypes are presented by the different colored spots. I think the most important dilemma is that the estimated number of oocytes that are needed for pregnancy in Turner syndrome is unknown, and that worries me a little. So if you consider that women below the age of 35 without Turner syndrome needs about 15 vitrified oocytes for a live birth rate of about 70%, and 25 vitrified oocytes result in a live birth rate of 95%. And if we look at the case report of the one woman with Turner syndrome who got pregnant after this procedure, she had 29 vitrified oocytes, and that resulted in 1 pregnancy. And if we note that women with Turner syndrome unfortunately have a high risk of miscarriage, I would estimate that you might need 35 to 50 oocytes for a live birth rate of 95%. So if we go back to the graph, and you can see the numbers of vitrified oocyte, the cumulative numbers after multiple cycles, it doesn't seem very realistic to have this high number of accumulated vitrified oocytes in women with Turner syndrome. So the live birth rate will never be 95% in these women after this procedure, in my opinion. So therefore, I think realistic counseling is very important. So my conclusions about oocyte cryopreservations are that it is an option for adolescent girls with Turner syndrome and spontaneous puberty, and of course favorable AMH levels and genotype. These are very important predictors for success. However, this is still statistics, and it doesn't necessarily say something for the one individual girl. Often you need multiple stimulation cycles for the retrieval of sufficient oocytes, and I do not know what will be sufficient, because there are very limited data about live birth rate after the use of vitrified oocytes. So realistic counseling is very important. Then I would like to focus on ovarian tissue cryopreservation in Turner syndrome. This, as I said, is a surgical procedure where you take a biopsy, or you can have a unilateral ovariectomy, and you freeze part of the whole ovary for later autotransplantation in the adult woman. This is a successful procedure in women, for example, who need toxic therapy in cancer treatments. So this is not an experimental therapy in women with healthy ovaries. But in girls with Turner syndrome, it is an experimental therapy. And the most important pro of this treatment is that you can do it at an early age when there's still ovarian capacity left. And if you look at the literature, until recently, there were 102 cases described in the literature, and it included one large, very interesting cohort of our Swedish colleagues of 57 patients. And in about 26 to 67 of the cases, follicles were found in the ovaries, and it's largely based, of course, on including bias. But until now, there are no follow-up data for these patients, and there are also no live births reported. So we thought this was a very difficult question because we wondered if it was ethical to offer OTC in young children with Turner syndrome. Because of course we do not want to cause any harm to our patients with Turner syndrome. And we talk about very young children and they are incapacitated. And how about bodily autonomy? We do not know what the quality of the follicles will be and whether this option is really an option for these girls with Turner syndrome. So that's why we performed an ethical study. It was the consensus study, and with many colleagues from many different countries all over the world. It included pediatric endocrinologists, gynecologists, ethicists, and patient representatives. And we discussed the main ethical themes: beneficence, autonomy, non-maleficence, and justice. And with this team, we concluded that we could or should offer ovarian tissue cryopreservation to females with Turner syndrome, but only in a research setting and only with proper and experienced counseling, and long-term follow-up should be part of the procedure. And that's when we started with the Turner fertility trial. And this trial is to investigate the occurrence of live birth in women with Turner syndrome after OTC in childhood. So we promised our ethical committee to focus on live birth, and that's our primary objective in our study. And that means that our study will continue until 2070. So it's not about careers of people, it's about the follow-up and taking good care of all these girls and women. So part of our selection procedure was that all patients and parents should attend plenary information session. Of course, patients if they were able to, depending on the age of the patients. And there were 189 parents and patients that visited our plenary sessions. And we performed 173 individual consultations. And finally, 160 patients and parents signed the informed consent form. And 13 patients dropped out, most of the time because of poor odds, because our counseling, we counseled our patients continuously also during the study. So based on negative results for some subpopulation of patients in our study, parents and patients decided not to continue for the surgical procedure. And there were other reasons for people to drop out as well. And finally, we performed an OTC in 93 patients, and I'm going to show you the results now. This is just an overview of our patient cohorts. The mean age of our patients was 12 years old, and well, about 40 to 50% of the patients were prepubertal, and it was more or less the same in all genotypes. And it will not surprise you that the spontaneous puberty was more often in patients with a mosaic 46XX genotype. So in this graphs, you can see in orange those cases in who we did not find follicles present, and in blue those cases in who we did find the follicles present. And unfortunately, we were only successful to find follicles in one patient with a monosomy 45X, in about 2/3 of the patients with mosaicism 46XX, and in about 1/4 of patients with other genotypes. And we were most successful, which will not be surprised. You will not be surprised for this, in those patients with a spontaneous puberty. And about 1/3 of our patients was still pre-pubertal when starting this procedure. If you look at those 26 girls with follicles and no HRT treatments, almost all girls had a measurable AMH level and an FSH level below 10. But also here there are always patients who are an exception, like this patient with an FSH level which was high, a low AMH level, but she did have follicles in the ovaries, which is the blue dots. And also this patient here below with a low FSH level and a low or undetectable AMH level had follicles in the ovaries. So I would like to share some lessons learned or maybe insights that I have after this Turner fertility trial or during this Turner fertility trial. First of all, the insight that the ovarian cells have different genotypes and the oocytes usually have a normal genotype. Maybe for the pediatricians or endocrinologists who are not familiar to look at ovaries, I maybe just wrap up. If this is a normal ovary, you have different stages of follicles over here. And if this is the oocytes, it's been surrounded by granulosa cells, which supplies the cells with nutrients for growing. And then there's this supporting tissue over here, which are the stromal cells, and it is the supportive tissue of the ovaries. And I think it's very interesting our laboratory technician and specialist found a way to split up the different cell types in the ovaries and then to look in more detail to the genotype of these cells. So for example, maybe I start with the patient on the right. This patient on the right had a mosaic 45X, which are the black bars in the buccal cells. And also this patient had a 46XX, which is the gray bars in the buccal cells. And also in lymphocytes, there was a mosaic genotype. While in the urinary cells, this patient had a full monosomy 45X. But then if you look at the ovarian cortex and you look at the different cells in the ovarian cortex, you can see that in the granulosa cells, you can find only 45X, while in the stromal cells, which are the supportive cells, there is also a mosaic pattern. And most interesting, I think, is that the oocytes had a normal genotype in all oocytes, in this case, that we checked. And if you look at the patient on the left, this patient had 3 different cell lines, also the 46XX cell line in all cell types in the body here. But if you look at the ovarian cells, there's a difference in between the different cell types, and almost all oocytes had a normal genotype, which is supportive, I think. So how does that look under the microscope? These are xenografted oocytes, so with larger granulosa cell layers, and we performed FISH on these cell layers, and with red color are the chromosome X chromosomes, and we compare them with the chromosome 18, which is shown in green. For example, in these granulosa cells, you only see, or hardly see, you see much more red signals than green signals. That's because of these, the genotype of these cells is mainly 47X, triple X. While in these patients, for example, you see much more green signals than red signals, and that's because of this patient mainly has 45X in the granulosa cells. If you would like to know more details about the procedure or the technique, I would like to, you could read this in this paper where we showed the specific technique. So next, I told you before that we have one girl with a monosomy 45X and follicles in the ovaries. And I think this was a very interesting and special patient. This is the patient, this is the one monosomy patient, and on a macroscopic level, the ovary looked normal. It was a 14-year-old patient with 45X in both lymphocytes, buccal and urinary cells, no signs of puberty, with a FSH of 5.2 units per liter and a measurable AMH, and she had one normal ovary, which is this ovary, and one streak ovary, and we found 2,700 follicles in this girl. And if you look at these follicles, you can see primordial follicles over here, and these are secondary follicles over here. And still, these follicles do not look really normal. The granulosa cell layer of these follicles is irregular. It's not normal. It's thickened in some ways, and also the surrounding is quite thick. So the morphology of the follicles in girls with Turner syndrome is not always normal, and it is described in earlier papers before. And please watch out, because we changed the colors of the green and the red fish. So the red signs here show the chromosome 18, the control chromosome, and the green lights show the chromosome X. So again, you can tell that in some cells here you have a 47 triple X, and in other cells you have a monosomy of the 45X, and this is the oocytes. And this is the graph. It's comparable with the graph that I showed you before, which shows that you have 45X in 150 cell lines, and in the ovarian cortex you have different cell lines. But again, the oocytes mostly have a normal genotype. Well, what happens if you transplant these follicles, this ovarian tissue, and try to make them grow? In collaboration with our colleagues, Professor Dolmans in Belgium, we performed xenografting after permission of the parents and the patients, of course. We performed xenografting of the tissue in mice models in Belgium. And there we saw that our follicles could grow, and even antral follicles or hemorrhagical follicles were grown after xenotransplantation. And I was really relieved, because this was a kind of proof of principle, proof of concept that this technique could work after transplantation. And what's also interesting is, as I showed you, in the primordial follicles, oftentimes you have 45X granulosa cells surrounding the oocytes, which is colored here in orange. But after xenografting, while the follicles were growing, we saw, it was very surprising for us, but that the number of 45X genotyped granulosa cell decreased. So whether only those oocytes can grow with high percentage normal genotyped granulosa cells, or during the process of growing, only the healthy granulosa cells could divide in more cells. We don't know, but it's very interesting, and we saw this in many patients. So before xenografting, these are just 2 patients. Some of them had 45X in all granulosa cells, or in almost all granulosa cells. And after xenografting, in the secondary and enteral follicles, we saw almost only 46XX genotypes, or in most of the granulosa cells, 46XX genotype. So I think this is interesting. Furthermore, we have a follow-up of these girls. We started with our procedure in 2018. So now we have a follow-up period of 1 to 4 years, so still very short. But until now, we feel that the procedure has little impact on puberty, at least on the short term. This is a complicated figure, so I will lead you through the graph. So these in green were all the patients before the OTC, and different, like if it's full green or striped, it depends on the genotype. And if you look at the prepubertal girls who had OTC, almost all of these girls had spontaneous telarchy, spontaneous menarche, and regular menstruations. Of course, some of these girls are still too young to experience spontaneous puberty, and there's one girl who needed hormonal sublation therapy after OTC. And also in those girls who had spontaneous puberty before OTC, most of them still have spontaneous ovarian function. Of course, there are some girls who are on HRT now, but that also, of course, occurs, of course, in the general paternal population, that didn't, in girls who did not have OTC. And it's very important, I think, to perform a longer follow-up, of course. It sounds like I only have nice and good news. Unfortunately, that's not true. If you look at the estimated ovarian reserve capacity in those girls that we performed OTC on, the estimated ovarian reserve capacity is very, very low. For example, if you look at this picture, in our best patients with the 46XX genotype, one of our best patients had, let's say, 100,000 follicles in the ovary. It's the estimated amount of follicles. And if you compare this with a healthy female population, 100,000 follicles is comparable with women of the age of 35 or 40. And we know that in this woman, the fertility already is declining. So these are even our best patients. So you can imagine that in those patients in who we only found 100 or 2,000 follicles in the ovary, you can doubt whether it's realistic, whether it will be realistic to have a pregnancy after ovarian tissue transplantation in the future. And then we need other techniques which are not possible at this moment, like in vitro techniques or things like that, for maybe pregnancy in the future. Because of course, after grafting, these are the results of our xenografting study. And in blue, you can see the control population and the density of the follicles in these girls. And of course, the follicle density decreases after grafting. And this also occurs in our girls with Turner syndrome, here with orange dots. And in the peri and post-pubertal phase, the amount of follicles are even lower than in the girls with the pubertal stage. Well, the survival of the follicles isn't that bad, even not in our girls with Turner syndrome. The survival rate is a little bit less than in the healthy controls, at least in the post-pubertal and the peripubertal girls. But they just start at a lower density rate. So interpersonal variability is high, and that was also a problem in our study. For example, if you look at AMH level, which is in general has a very strong correlation with the ovarian reserve, as this is the estimated ovarian reserve. But for example, even if you have this girl with a very low AMH level, she has a relatively high ovarian reserve. While these two different girls with a high AMH level has a very different amount of ovarian reserve capacity. So you can imagine that the counseling for this procedure is challenging. And that's also what we heard from our colleagues. We performed focus group sessions in a qualitative study concerning counseling of girls and parents with Turner syndrome. And gynecologists, pediatric endocrinologists, and pediatricians were included in these focus groups. And they told us that they believe that the counseling for this procedure was really challenging. And also we learned a lot from our patients. They gave us very valuable insights, and time's too short to address these all. So if you're interested in the results of this study, please read our paper. But we asked patients and parents who opt for, but also those who opt against OTC. We asked them after a period of time how they feel about the decision. And they gave us very valuable insights that will help us in our future counseling process. So my conclusion about OTC is that it's still very experimental in girls with Turner syndrome. That happily small follicles can grow to antral follicles, so we have kind of a proof of concept, and that the oocytes often have a normal genotype. And that also in this study, follicles were mostly found in those girls with a positive or a mosaic genotype, spontaneous puberty, and favorable hormonal markers. But it's still very difficult to predict in a single patient. And still there are no live births reported so far, and we do not know how many follicles are needed for a realistic chance for pregnancy. And therefore counseling for OTC is very challenging and needs a lot of expertise. Well, recently I need to tell that there is one publication of one woman who became pregnant after ovarian tissue transplantation, but unfortunately she had a miscarriage after 6 weeks of pregnancy. But I hope there will be future cases reported. There will be cases reported in the future. So, in summary, I didn't tell you so far that only 1 in 10 girls with Turner syndrome receive proper specialized fertility counseling. This worries me a lot, and I think we all have work to do to increase the percentage of girls and parents who will have proper fertility counseling. And this counseling, I think it would include evaluation of biopsychosocial needs. If possible in your center, please determine genotype in different cell lines and monitor hormonal markers frequently. And maybe even in mini-puberty if you have the possibility and early diagnosis. In collaboration with our Danish colleagues from Copenhagen, Casper Hagen and Anders Schul, and many collaborators and colleagues from Europe, we soon will publish our paper about the mini-puberty hormonal values of girls with Turner syndrome. And I think if you have the possibility to monitor these hormonal markers in a very early infancy, this could help in future counseling. And I think we should refer all girls and parents for fertility counseling at the age of diagnosis and also at the age of adolescence and in adulthood. And these recommendations are in line with the international guidelines from Aarhus meeting that we recently published as well. On the right side of this graph, there's just a short summary of what we could discuss in the counseling process. And of course, the odds for natural conception depends on the genotype, as we discussed before. And the success for fertility preservation depends on a detectable AMH level and the genotype as well. But the success is defined here as the success for finding follicles, and that still doesn't necessarily mean success for pregnancy. Of course, reproductive techniques like IVF and ICSI is important to address in your counseling process, the alternatives to parenthood, but also important the option to remain childless. And we discussed this in detail in the Aarhus during our guideline meetings, that some patients and girls feel that there's too much stress about the only option for a happy life is becoming a mother, and maybe we could or should frame this differently as well. Okay. So finally, I can imagine that all these data might confuse you in what to tell or how to navigate in the fertility dilemmas that are there in the counseling process for girls and parents with Turner syndrome. And that's why we published this review paper on this topic. And this paper also includes a practical guideline for fertility counseling in Turner syndrome. And I'm not going to discuss this in detail, but first of all, of course, you need a multidisciplinary team for proper counseling. If you do not have this team in your clinic, please refer your patients for this counseling process to another clinic that has the opportunity to perform this counseling in a multidisciplinary way. Step one is the assessment of the fertility potential, which we discussed before with a precise genotyping and hormonal evaluation. And then step two is the counseling for the different options. And I do realize we discussed in our group, we discussed a lot. Of course, the editor of the journal pressed us to put a definite image level, a cutoff level for your counseling process, which is of course very difficult. And there's of course what I told you, a very broad inter-individual variety, and also it's about shared discussion, shared decision making. But we also feel that, of course, if you have measurable AMH levels, so below 1.5, you have a chance to find follicles in the ovaries, or find follicles for vitrification in the oocyte cryopreservation. But whether you will find enough follicles in the girls with the AMH level below 0.1 for realistic pregnancy, in the future, at least with the techniques that are available at this moment, we do not know. And that's why we have this cutoff level of 0.5, which you can discuss, of course. And step 3 is monitoring, on monitoring of hormonal status, monitoring of psychosocial status, and continue counseling in a later stage. Well, finally, for further reading, of course, our recommendations are in line with the clinical practice guidelines, but our recommendations are also described in more detail than the clinical guideline. But please take a look at this clinical practice guideline, where many of you are probably involved in, and also ERN is involved in this clinical practice guideline, and a patient-friendly version is upcoming. So again, thank you very much for attending this webinar, and also a special thanks to all the patients that participated in our study, and all the parents and collaborators. Thank you very much.
Thank you, Janielle, for this excellent presentation, excellent talk, and a lot of new information, I think, for all of us, or for many of us. And I think that there will also be some questions. There are some questions in the chat, but first of all, I would like to give her the opportunity to Aline to comment on this talk.
So thank you so much. It was so interesting, and I'm so glad that you're covering this topic, because I feel it's a real challenge for families.
So Mary, I ask you, Janielle, just to unshare your screen, because we see now a lot of
sorry.
Yeah, that's it. There we go. So I feel for families, the not knowing it is really challenging, and with the counselling they could perhaps adapt. So I think it's just wonderful that you're considering options for the future, but you're being realistic with them, and I think that's a proper balance to have. I think for parents, speaking as a mother, I think it's always a challenge for the mother, and we must always remember this is about the individual with Turner syndrome, and try not to put our feelings on to our child, which is not easy as well. So thank you very, very much. We do have a question from Luca. It's quite a complex question, which perhaps Hedi would be better to discuss with you, because it's very interesting.
Yes, this is a question about genetic testing, and at least about the which tissues should be tested. As you mentioned, that there are variability in different tissues, and he mentioned, after congratulation, of course, that in the past they tested mosaicism in several tissues of 30 patients, and they did not uncover major differences by CGH array among blood, buccal, or vaginal mucosa or hair follicles. So his question is, what tissue would you suggest to test?
That's a very interesting question. Thank you for the question, and it's a difficult answer as well. I think you can test as many cell lines as you wish. You will find a different pattern oftentimes. So it should be a practical answer. I think a practical answer is I would test 2 different cell lines, at least do a buccal smear. That's the most easy thing to do. Of course, you can take urinary samples or skin samples, but that's more difficult. And there are At this moment, there are multiple publications. Also, I didn't show you, I couldn't show you all the data, but also we perform buccal smears in our patients, and there are differences in between the buccal smear and the blood cells, and there are many other publications that shows the same. And if you think genotype is important in your counseling, which I think it is one part of the puzzle that you take into account when you counsel your patient. And if you think it's that important, you should be aware of the fact that you can have multiple cell lines. So I would always perform 2. And of course, I don't know whether the more is the better. So, yeah.
So I think it's still challenging to translate the clinical and biochemically biomarkers to the clear chance to be, to get to have for the fertility options. You told of that. There is one other question: can girls with classic Turner syndrome have this procedure? I think the procedure of the OTC, and I think somewhere in your talk you mentioned that already, but probably you can comment on that again.
Well, I think this is a very good, and these questions are this is the most important. I think it's about shared decision making. But in our patients, we decided together with our patient organization to include all patients in our study. So we did not have inclusion criteria like mosaic or whatever, because we wanted to know for sure that we didn't exclude patients on forehand. But that resulted in the fact that we only had what I showed you, one patient with a monosomy, and this patient had 2,700 follicles, an estimated number in the ovary. And as I showed you, I doubt whether this amount of follicles can give pregnancy in the future with the techniques that we have at this moment. So we counsel not very optimistic in our monosomy patients with Turner syndrome. Because of course science is one thing, you can find things, but it's not about science, it's about this one girl with this specific question, a realistic counseling.
And that would be the case because the 1 or 2 very rare cases where it's a 45X lady that's had a pregnancy, those pregnancies tend to have been conceived very young. So,
Yeah.
Therefore, probably the reserve was low, but they were lucky.
Yeah.
If
If you have normal, of course, yeah. So, of course, we know sometimes you have a patient with a monosomy and spontaneous puberty and favorable hormonal markers. I think hormonal markers are more important than genotype. It's about the hormonal markers. It's not about the genotype, because we know there can be a different genotype in the ovaries. This hormonal markers are the most important in counseling, I think.
Yeah, I agree. Yeah.
And you told us that there's also in those with spontaneous puberty, there is a higher frequency of higher percentage of miscarriages in Turner syndrome. Should we also counsel for that? Is there also a kind of morphological problem of the uterus, or because that would also add to the problems that you would expect in oocyte transplantation?
Yeah.
Yeah.
That's a good question, and I don't know the answer actually. As far as I know, there are no uterus abnormalities or those kind of things. I think it has something to do with the genetic, with the genes, or maybe with the supply of these granulosa cells, which are not normal granulosa cells. So what does that mean?
So
Yeah.
sometimes there's a fluid that builds in the uterus which leads to miscarriage. Again, that's just anecdotal from hearing from people that that's been the main cause. And also getting the lining correct as well. The lining of the womb is often not quite, it's unevenly spread. So they thought, although thick in certain points, not thick enough all round for the egg to implant. So that's feedback from individuals that have told us.
So you showed that there are a lot of unsolved questions, but a lot of answered questions, and that you contribute to with your study. For now, it's time to close the session. It's 4 o'clock. Again, thank you for this excellent presentation, Janielle, and thank you to all participants. Thanks to Arlene for the co-moderation. And I hope to see you again for the next webinar of the MTG7 or the Endo-ERN as well. Thank you and have a good day.
Thank you all.
Thank
Bye.
you.